Now moving on to our next segment of the day is a session on diabetes and heart and how a pill is changing the future. The session is partnered by Novo Nordisk, and for this we have our presenter here, none other than Dr. Sandeep Bansal, Director VMMC and Safdarjung Hospital, who will shed light on how a pill is changing the future. We welcome you, sir. Thank you. Let's welcome him with a round of applause.
Uh, Good morning. Actually, as a teacher, I teach MBBS students also and MD students also, and I also teach my DM students. So somebody asked me, who are the most difficult to teach? So I said the MBBS students are the most difficult to teach. So as I see this crowd is not everybody is a medical doctor, so it is going to be tough for me to talk about this extremely. Uh, this is like what we call a journal club in our medical parlance. Every week, every teaching institution has a journal club. So this is essentially a journal club which talks of a specific pill, which has done a great job in some ways. The time allotted to me was actually 20 minutes. So kindly increase my time to 20 minutes and not 10 minutes. I'll try to be as simple as possible, but at the same time, the facts are going to remain facts. So this is something, this is a new concept. I'm a cardiologist, so are some of my colleagues here. We have people from different specialties. We have endocrinologists who look after diabetes, and we have, kidney specialists or nephrologists, as we call them. And for a long time, we believe we have a tunnel vision. As a cardiologist, I see only cardiology, and I think everything is related to heart. My nephrology colleague thinks it's everything related to nephrology. But now there's a convergence happening. This is a recommendation from the American Heart Association, which basically talks of cardiovascular, kidney, and metabolic continuum. So the three, actually happen hand in hand. They happen together. That's the basic point which is raised in this slide. And as we can see to the left, you can prevent it by what is called as essential 8, something that is often talked about but seldom followed, which basically refers to taking dietary precautions, doing some good bit of exercise, measuring your blood pressure, etc. And sleep. Sleep is an extremely important component of this. But as you go towards the right, you find that obesity comes in. Much to our chagrin, obesity is an epidemic in our own country also. There have been recent news reports, there have been recent articles which talk of 1 in 5 school children being obese. Obesity gives way to diabetes and hypertension, which is the stage 2, and then you start having subclinical syndromes or abnormalities which are detected by tests before you actually have full-blown complex of heart, kidney, and diabetes taking place together, and it is shown on the right side. Now, we also know, so as I said, we have risk factors. We have risk factors like high blood pressure. We have diabetes, we have lipids that we had a lot of talk about, and we have obesity. These are important risk factors. They lead to adiposity. Obesity particularly leads to insulin resistance, which can cause dyslipidemia, which means bad lipids. It can cause diabetes, and together they lead to inflammation in the body, and they lead to the complications which are shown on the extreme right of the slide. So we have a very important group of drugs which are called the GLP-1 receptor agonists. Please remember that there is in our body, in our pancreas, there are what we call as GLP-1 receptors. When we eat food, the we have some endogenous agonists, which means that they will activate those receptors. We have endogenous ones, but they are very short lasting. So these drugs, they go and sit on those GLP-1 receptors. So that is why they are called agonists. This, releases a cascade of reactions within the cells, and that leads to higher insulin secretion, which is the glucose lowering hormone, and a lower glucagon secretion, which is a glucose raising hormone. So in simple words, that is how the GLP-1 receptor agonists help. And they help by controlling the glucose, which is HbA1c, causing body weight reduction, giving you cardiovascular benefits, which have been highlighted on the right side. And they act through different organ systems. They act through the brain, decreasing the satiety. They act on the liver, making it healthier. They act on the kidney, preventing kidney damage. They act on blood vessels to increase the blood flow, and they stabilize the plaques. They stabilize the plaques means they prevent heart attacks, and they also reduce inflammation. What are the what are the problems with our own population? We know that as compared to global population, we have almost 2 to 4 times higher risk. And if you compare to the population which is in the East, the Japanese and the Chinese, it is 6 to 12 times. It was already highlighted 10 years. I would say we are actually almost 15 to 20 years earlier as compared to the Western population. And 1/3 of the people who have diabetes of any duration, they are bound to develop heart problems. And more than 50% of Indians who are more than 50 years of age and have diabetes have heart problems. We also understand that diabetes is such a problem in India that 1 out of 5 diabetics have a problem which has been highlighted here. They'll have peripheral arterial disease, which means less blood going to their legs. They have angina, or they have a heart attack, or they have a stroke, or they develop heart failure. One of these 5 or 6 things occurs in 1 out of 5 diabetics within 5 years of the diagnosis. So that is the kind of problem we are looking at. And the important thing is that this class of medicine has come up in last about 8 to 10 years, and they have been rapidly recommended by almost all the bodies, whether they are cardiac bodies or they are diabetes or endocrinology bodies. Now, while this is known to give you cardiovascular benefits, the important thing is the drugs on the right side. If we see, the most commonly used drug in diabetics is metformin, which is about 85% of people, and rightfully so. It has to be metformin which has to be used. The GLP-1 receptor agonists, which are again recommended, we don't have the clear numbers so far. Very, very minuscule population is on GLP-1 receptor agonists. The SGLT2 inhibitors is another class of drugs which make glucose go through the urine and pass out in your urine. That is the way they act. So they are used in less than 5% of diabetics. These two classes on the top, they are the most preferred anti-diabetic classes of anti-diabetic drugs, but they are used in a woefully small number of patients. As I said, they are recommended across the globe now by cardiac, even renal. The KDIGO has been mentioned here, and the diabetes guidelines to mitigate the risk of cardiovascular events. See, we need to understand that 75% of diabetics do not die because of diabetes. They don't die because of sugar. They die because of cardiovascular problems. 75% of them. So that will include a heart attack, that will include a stroke, and that would include peripheral arterial disease. We must have heard or heard about so many people, having to get their legs amputated or their the fingers or the limbs amputated. That's peripheral arterial disease. Less blood is going to go to the peripheral arteries. So the second commonest drug after metformin, which is recommended, was a category of drugs we call as DPP-4 inhibitors. And these are used in about 60% of diabetics in our country. But the point is that they are not protective. They are not benefiting you in any way. And this has been, I can talk about it, but I don't see a point. Suffice to say that they do not benefit you beyond the control of sugar. Whereas, if you make a comparison, when you compare the GLP-1 receptor agonists that we are talking about, there are absolutely clear benefits across the board, including all-cause mortality, which means your chances of dying are almost 35% less if you use a GLP-1 receptor agonist as compared to the most popular category of drugs that are being used. We also need to understand that despite using so many anti-diabetic drugs, there is a lot of what we call as residual cardiovascular risk, which means you've used the drug, but in spite of that, the risk remains. And these risks, these are again slightly technical matters, but there is a residual obesity risk, there is a residual risk of diabetes, there is a residual lipid risk, and also thrombotic risk. All these cause a higher number of heart attacks and cardiovascular problems. So the important thing is that although this drug has been clearly in use as an injectable, a weekly injection, it is now available in the form of tablet. And this is a trial which was done, which is called the SOUL trial, close to about 9,500 patients. And about 8% of the total number of patients were from India, about 800 patients. And in this, there was a category of patients who were given semaglutide, which is a GLP-1 receptor agonist, and the controls were not given this particular drug, but they were given standard of care. Whatever medicines are to be given, they were given. And there was a clear control. The features have been highlighted here. Nearly 70% of them were males, and the Asians were about 25% of the population. They were obese people. The mean BMI, as we see here, is 31. But the important thing is that almost 90% of them had hypertension. So this was the category of drugs. So who were the people on whom this trial was done? They had diabetes. They had a complication of diabetes. It could be a heart problem. It could be a kidney problem. And to those 10,000 patients or 9,500 patients, half of them were given the drug, half of them were not given the drug. So this shows the different complications that were there in different groups, and almost 45% of them had renal problems also. What was seen was that concomitant medicines or accompanying medicines were given in almost equal numbers in all the patients. And what we find is that there is a significant there is a significant 14% reduction in what in medical parlance, we call it as a 3-point MACE, major adverse cardiovascular events. So they included death due to heart attack, a non-fatal heart attack, or a non-fatal stroke. So this was decreased by about 14% in all these patients. There was the important thing, as I said, the major benefit of this class of drugs has been decreasing the chances of having a heart attack, and there was a 26% reduction in the heart attacks. In the Asians and in those whose controls were bad, the average HbA1c in Indian population is about 8.5, And so those people who had a bad HbA1c, a bad diabetes control, there was even greater benefits. And as far as the kidney benefit was concerned, there was a clear kidney benefit. And as we can see, that the estimated treatment difference was almost 60%, which means that whether you use this drug or did not use this drug, there was a clear kidney benefit also. And again, this talks of the kidney benefit once again. And as far as as I said, there are two important categories of drugs. One is the GLP-1 receptor agonists, and the other is SGLT2 inhibitors. And this highlights the two different groups and what are the modes of actions of these two different groups. The evidence suggests that if you combine these two categories of drugs, the management of diabetics is more effective and their cardiovascular mortality is reduced together. And if we compare with giving this combination versus either of these drugs, we see that there is almost a 30% decrease in the heart events, and there is almost a 30 to 60% decrease in terms of the kidney problems. So these, as I said, the three occur together: cardiovascular, kidney, and diabetes. So because of diabetes, if you use these drugs, there is a 1/3 decrease in the cardiovascular problems, and there is about a 30 to 60% decrease in the renal problems. There's been a lot of there have been a lot of other studies which have been done, close to 2,000 patients, and they again show that if you use a combination of these drugs rather than one drug alone, there is a clear benefit. And even all-cause mortality or the chances of dying, see, these are drugs which actually decrease the chances of a diabetic from dying as compared to the people who don't get these particular medicines. Again, these are technical things, but again, suffice to say that this combination is beneficial for the kidneys, and it is also beneficial in terms of the heart or the cardiovascular events. And the combination, as I said, if you consider these people over a period of 5 years, so you study these people, you see how many died in the next 5 years. There is a significant mortality difference if you use the combination of these two important drugs. And when added together, they also cause a greater weight loss, and they also cause a greater better control of diabetes, and they can be very comfortably added to metformin, which I said is used in almost 85% of the diabetics in the country. If we talk of pharmacological remission, when do we say there is a remission of diabetes? When your HbA1c or 3-monthly average sugar is less than 6.5. So that is again achieved in much higher number of patients, almost in half of the patients, if you use this particular combination. So risk of heart attack is reduced, the risk of stroke is reduced, and if we look at the broad actions in terms of reduction of cardiovascular death, both are beneficial. In reduction of stroke and heart attack, the SGLT2 inhibitor, the GLP-1 receptor agonists are helpful. And in terms of reducing heart failure, the SGLT2 inhibitors are beneficial. So we need to understand that this particular category of drugs, whether given orally or in injectable form, is better. The important thing is, why are we talking about this oral drug? In a common public parlance, the injectable therapies are generally accepted by only 10% of the people who are ready to accept the oral medications. This is if you are giving a daily injection. So people have studied, if you want to give insulin, only 10% of people would want insulin or accept insulin as a form of therapy. This is, of course, a weekly injection. The acceptance must be higher, but the exact differences are not known for this weekly injection. So, to summarize, we need to understand that when we use these two classes of drugs, we benefit the heart, we benefit the kidneys, we help our patients have lesser heart attacks, and we let them live longer. I thank you for your kind attention. If there are any questions, I can take them, but I don't know, I try to make it as simple as possible.
So I'll invite Pinky from VOH. Sir, if you could please be with us. I'm inviting Pinky ma'am from VOH to please, we wish to offer a small token of our gratitude to you, sir.